Hello, I'm Professor Megid El-Nahas, retired professor of medicine and nephrology at the Sheffield Kidney Institute, University of Sheffield in the UK, and past director of the Global Kidney Academy and the Sheffield School of Nephrology. Beside my interest in clinical nephrology, CKD, research and clinical and experimental research into CKD, I've set up the Global Kidney Academy with my colleagues at the Sheffield Kidney Institute and the Sheffield School of Nephrology, with one thing in mind, is to transmit and teach younger generation of nephrology, and we have done this over almost 25 years, if not 30, where young nephrologists came from all over the world to the Sheffield Kidney Institute to get certificates and diplomas and PhD from the Sheffield School of Nephrology. And the emphasis has been all along not to impose spoon feeding on young minds. The most destructive thing is spoon feeding type of learning, and the most constructive and long-lasting type of learning is reflective learning. When you think about what you learn, you think about its application and the context of its application to your given patient. Coming back to patient, the first thing to bear in mind is there aren't two patients alike. Each patient is unique. You have to put yourself in the place of this unique patient and tailor your approach to him, investigation, management, and diagnosis, or investigation, diagnosis, and management, to that particular individual. Remember, every patient is unique. And also remember, you're not treating a condition. You're not treating a nephrotic syndrome. You're not treating a diabetic nephropathy. You're treating a patient with nephrotic syndrome. You're treating a patient with diabetic nephropathy. So you're not treating a condition. You're not treating a kidney or two kidneys. You're treating a whole individual with a given medical nephrological condition. And you have to tailor your approach and you have to tailor your treatment to that particular patient. Put yourself in his place and tailor your treatment, individualize your treatment to the individual who is in front of you and who you are responsible of management. And apply this reflective thinking and reflective practice to your approach. And that's what I aim to share with you today. An approach consisting of 5 questions. The 5 whats. What is my approach for? What is the evidence, the validity of my approach? What is the utility of my approach? How is it useful to that particular individual? The risk that I'm imposing on this patient and the benefits, so a risk-benefit analysis, and finally the cost, a cost-benefit analysis. So we look at why or what for, what is the evidence, what is the utility? Is it useful to that particular patient? What is the risk-benefit analysis or ratio? And what is the cost-benefit? Let's start with the first what. What is it for? What is this investigation for? What is this treatment for? And it always has to be for the benefit of the patient. Don't do a kidney biopsy for the sake of finding out the type of histology and the subgroup of an FSGS or another type of nephrotic syndrome, if you know how to manage the nephrotic syndrome without the biopsy. Don't biopsy a diabetic patient just to know what type of histology reflects his nephropathy, when you won't change the management of a 85-year-old with 2 grams of proteinuria or even nephrotic range proteinuria secondary to type 2 diabetes, and so on and so forth. So ask yourself, what am I doing this test for? Is there an alternative test which will be more acceptable to the patient? Or do I need to do the test? Will it benefit him directly? Never mind benefiting me. You are not in the business of learning at the expense of the patient. We are at the expense of the business of benefiting the patient through our learning. What am I treating him for? Do I need to treat him? Would the test make any difference to his management? If the answer is no, don't do it. And the management has to be tailored for that particular patient. Which takes us to the second point. What is the evidence that what I'm doing is correct? What is the evidence that the latest type of isotope scanning or PET scanning or MRI is beneficial and appropriate to that particular condition? What is the evidence that the treatment, the latest treatment with the latest monoclonal antibody for a given nephrological condition is validated, is superior to what is considered conventional medicine? For a test to be validated as superior, it has to be compared in a randomized clinical trial with the best current clinical practice. No good testing a monoclonal antibody on 3 patients with nephrotic syndrome or rapidly progressive glomerulonephritis, talking about it or putting a poster in a conference or giving a 5-minute presentation and saying that is the way forward. You need validation by clinical trials. You need validation by statistical analysis. You need validation by the number of patients needed to be treated to improve one patient. The smaller the number, the more effective the treatment. If to improve one patient, you need to treat 10,000 patients, that's not an effective treatment. If to benefit one patient, you need to treat 5,000, it's not effective. 1,000, at least 100 to benefit one. And there should be good evidence from clinical trial, from statistical analysis, that this is a valid approach, valid investigation, valid treatment that you're putting the patient through. And remember, you're treating an individual, not a condition, not a kidney, not 2 kidneys, a whole human being. And put yourself in his place. Is this a good enough treatment? Is this a valid enough treatment to benefit him? Third, the utility. Is it useful to that particular patient? In management of nephrotic syndrome in children, is it applicable to an 85-year-old with nephrotic syndrome? Management of renovascular disease in Eskimos, is it applicable to a patient in your village, in your town, in your city, in your country? Furthermore, you're not treating kidneys. You're not treating a condition. You're treating this patient. So is this particular approach suitable for this particular patient? The utility may be useful in Canada, may be useful in China, may not be useful in Egypt, Bangladesh, or Nigeria, or even Mexico. The fourth what? What is the risk-benefit? You've established the treatment was effective, valid. You've established the treatment would be useful for this particular individual you are managing. Now, it is beneficial, but is the risk, the side effects, the complication of the treatment more significant than the small benefit he will gain from your approach? If that is the case, then the treatment is not appropriate. The risk, the side effects, you should know. And you should tell your patient before you embark on your management. This is a treatment that will benefit you, but there are side effects that I would like to draw your attention to. This is a treatment that may, and you give the percentage of chances, lead to remission or improvement or partial remission of your condition, but there are side effects that you need to be aware of. And you discuss it with him, and again with that particular individual, and you come to a shared management plan that takes into consideration the benefit and the risk. And if the benefits are higher than the risk, you and him will decide to go ahead. If the risk is higher than the benefits, he will turn it down. If the risk and benefit are balanced, he may decide to go ahead, and he may decide not to embark on that type of treatment. Risk-benefit analysis. And finally, cost-benefit analysis, especially when the treatment is costly and in the context of this particular individual that may or may not have a medical insurance, that may or may not have to pay for his treatment, the cost is crucial. And if there are two comparable treatments, one much more expensive than the other, choose the cheaper. For the patient, for the society and your medical practice, and for the healthcare in general. Why choose an expensive treatment because a drug pharma representative came by and told you that's the best treatment, but it costs $10,000 a year, when there is a much older, cheaper phosphate binder that costs a few $100s or pounds a year. So a cost-benefit analysis is important. Don't be led in your practice by the pharmaceutical industry that wants you to prescribe the latest, the most expensive medication to make them earn a lot of money. Think of your patient. Always put yourself in the patient's place and think about the cost. That's number 5. Think about the side effects. What is the risk-benefit? The risk to that particular patient. The usefulness, utility of your approach to that particular patient. The validity of that approach to that given patient, and make your treatment holistic in a way that you individualize it, you tailor it to a given patient. And this is how you will become a good, effective nephrologist, a good and effective and safe physician as a whole. So I think this concludes my talk. 1, put yourself in the patient's place. Don't impose anything on him. Management is a partnership. Patients are unique. There aren't 2 patients alike. You're not treating conditions. You're not treating kidneys. You're treating human beings and patients. And in order to treat them well, ask yourself the 5 what. What am I doing this for? Is it valid? Is it useful to him? What is the risk-benefit? What is the cost-benefit? Thank you. Have a good practice. Enjoy medicine and nephrology, and be proud of being nephrologist. It's the greatest medical specialty. Thank you.